Hello, everyone. My name is Judy Hervey, and I'm going to be talking about medication administration. We've talked already a lot about it, or if you're looking at this before class, we haven't. But we will be talking about this in much bigger detail. This is more of a broad overview, so that's why I'm recording it. So here we go, legal responsibilities. We all know in this field, such a litigious field because we put our hands on people and we can harm them. It is such a litigious area. So healthcare providers that are legally permitted to write scripts in the United States are obviously doctors, advanced practice nurses, dentists, and physician assistants. Well, let's go back to the advanced practice nurse. I want you to have an understanding of this. What that means is that has to be a nurse practitioner that is licensed and has gone through different classes of licensing and a different level of pharmacology than we will be doing here. And you're considered an advanced practice nurse if you have a master's degree. But for instance, mine is in education. I cannot write scripts. But I have friends that are pretty much level with me with a master's degree, but they're nurse practitioners, so they can write scripts. So just to validate that for you. Healthcare providers are responsible for obviously getting a client's medical history and physical examination. We need a medical history because the biggest thing with medications a lot of times is, have they had the drug and do they have an allergic reaction to it? They're responsible for diagnosing what's wrong with them, prescribing medications, obviously monitoring the response to therapy, and that's where nurses come in big time. We are a lot of times the monitor. The doctor orders the treatment, the drug, whatever, but it's the nurse that's there monitoring it. And you will hear me talk about that in detail throughout this course. And then modifying medication orders as necessary. Did they respond in what we call an adverse way? Did they respond like the majority of the population doesn't respond? Are they allergic to it? So forth and so on. Another thing nurses are responsible for are preparing the medication, usually outside of the room, or if we need to draw something up, we might be doing that at the bedside. Administering is actually giving them the medication, and then evaluating the client, evaluating that response. How did they react to it? If it's a brand new medication, it would behoove you to come back in 40 minutes to an hour, depending on what you gave, to see how they responded to it. If it's an IV medication, of course, that's instantly. Developing and maintaining an up-to-date knowledge base of medications that you're administering, including how it's used, the mechanism of action, the routes that we use, safe dosage range for the age and the height and weight of the person, adverse or toxic responses, precautions and contraindications, which we will talk about in class. A skill competency, you have to know what you're doing, and if you don't do it. Go get someone to help you with it or to show you how. And then the knowledge of the acceptable practice, and this ties into the Nurse Practice Act. What you can do in every single state may differ. Some of the states so much alike, but others not. So you need to be cognizant of where you are and what your Nurse Practice Act for that state will cover you and what you're allowed to do and not to do. Let's see, I think we looked at different accuracy of medications. Reporting all med errors. A lot of nurses are very much afraid, used to be much more punitive than it is now, to say, you know what, I made an error. But we really need to know early on because maybe we can intervene and fix it. Safeguarding, how do we store medications? Some medications need to be enclosed in like a dark brown bag if they're hung IV because they're very sensitive to light. Insulin needs to be refrigerated, so we have a very hard time with our homeless population that are diabetic. It's like, what did they do with their insulin? So we could go on and on about this. And then again, this is why I have it bolded. The prescribing, dispensing, and administering of medications is controlled by federal law, state law, and local laws, healthcare agency policies, excuse me, and each state's Nurse Practice Act, which I've already kind of alluded to. In medication orders for written policies, the types of medication orders, routine or a standard order, and that would be something that may or may not have a termination date on it. Without a specific termination date, the order will be in effect until the primary care provider or the doctor discontinues it or the client's discharged. Obviously, if they're discharged, we're not going to need the medication for them anymore. Certain meds must be reordered within a specified amount of time or it will automatically be discontinued, such as opioids and antibiotics. You cannot be on those forever. So other than that, if it's routine and they're in the hospital, a routine order might be given every day at 9 a.m. until it's discontinued. A single one-time order is just what that means. It's given one time at a specified time. It might be a potent diuretic like Lasix, 40 milligrams IV one time today at 10 a.m. And then a stat order means immediately drop what you're doing. We need to do it now. And a lot of hospitals have given timeframes for stat. In the units, ICU, CCU, DOU, the ORs, and ERs, a lot of times they have all that medication there. So stat means they run and grab it and give it. Or they run down to the pharmacy and run back and give it. Those people may be more acutely ill than on the floor, but who knows, maybe not. But on the floor in a lot of hospitals, and you have to check what that time order is, a stat can mean within the hour, but it means now. So if that stat order is ordered at noon and you don't have it by 5 to 1, I would definitely be walking to the pharmacy or calling them and saying, I need it right now. If they don't have anybody to bring it, you might have to go get it. And PRN is... it's a Latin, I don't have it written down here, but you will hear me talk about it in class. It's a Latin pro renata, I think it is, a term that means as needed. And so instead of saying Latin, and a lot of this stuff is grounded in Greek and Latin, we say PRN order. And that means as the person needs it. That's why it means as needed. It stipulates at what dose, what frequency, under what conditions a medication may be given. So it's not the routine where it's going to be given every day at 9 o'clock. It may be something like acetaminophen or Tylenol, 325 milligrams orally, PO, oral, every 3 hours, PRN for pain. So meaning you're not going to just give that every 3 hours, but you're going to give it when they need it, and you're not going to give it before the 3 hours is up. So it's PRN for pain. A lot of opioids are ordered that way. Morphine sulfate, MS, 1 to 2 milligrams every 3 to 4 hours, PRN for pain. And then they'll give you a pain scale of what type of pain they're looking at. And standing orders are just that. They're standing. They're there for, usually it's a specific unit, for specific circumstances on specific units. And I will give you an example. A CCU or coronary care unit is basically to deal with heart problems. And so when they have a myocardial infarction, another term would be a heart attack, they have standing orders as what are we going to do first, instead of calling the doctor and waiting till the patient dies to do anything. So that would be a standing order. You know, I've got a background in not only oncology, but obstetrics. In OB, we have standing orders for a postpartum hemorrhage because, again, somebody can hemorrhage to death in 5 to 7, 8, 9 minutes if you're in the arterial system. So are we going to wait until we hear from the doctor? Absolutely not. So we have standing orders for a hemorrhage. Okay, so that's what a standing order is. This is components of a medication order, and this will make so much more sense to you when you're in the hospital and looking at charts. We obviously have to have the name of the person, because if we give this wonderful medication to John Doe and it was supposed to go to Jane Doe, then that's a med error. So we have to have the name of the patient. If the name of the patient is not anywhere near the order or the medication, you cannot give it. The date and time of the order. I mean, is it a month old? Is it a week old? Is it an hour old? The name of the medication can be generic and brand name. And the beautiful thing for all you guys now is that when we used to have things written in charts, really dating myself here, and when I got out of school in the late 70s, early 80s, they were just handwritten. So it might have just been a generic name rather than the brand name that we're used to. Now with the computers, they have both. So it makes it a little bit easier. The dose, obviously there has to be a dose. If they just say, I want you to give Tylenol every 3 hours, PRN for pain, you cannot look at that. What is the dose? Is it 1 or 2 tabs? Is it 325 milligrams or is it 650 milligrams? Because we don't know what the doctor's thinking. The route, is it oral? Is it sub-Q? Is it intradermal? Is it IV? Is it topical? How do they want you to give this medication? And then the time and the frequency, exact or number of times per day. Are they getting it a one-time dose, once every day in the morning, once every day at bedtime, every 3 hours, every 4 hours, around the clock, every 6 hours? So that all, it's a one-time order. And then the signature of whoever's ordering it. Somebody has to own the order. Physiological variables affecting medication. Age. The younger you are, the tinier the dose. And of course, I deal with neonates and NICU babies, neonatal intensive care, very early. Normal gestation for a baby is around 40 weeks, but we may get these babies as early as 28, 27, 26 weeks. Same with the elderly on both ends. They're much more susceptible to a problem with a medication. The gender, the body build. Is there a chronic disease going on? Because if there is, then maybe some of their organs don't work as well as others as far as eliminating the drug. And those eliminating organs, we look at, usually they have to go through the liver to be eliminated. So if somebody is got chronic liver disease or cirrhosis or hepatitis, end stage, a kidney problem, a lot. The kidney is involved in a lot of excretion of drugs. Concurrent medication use. Sometimes medications used together don't do as well. The first pass effect, which, you know what, I'm going to stop right here because I need to talk about this a little bit more, and we will go on to the next video.